but also know that conversation will be continuing. Kojo Yankson interacting with Professor William Ampofo, who is head virology department, the Noguchi Memorial Research Institute. They are the forefronts of testing the cases, etc., alongside 3 other institutions. We also do know that we plan as a country to roll out more testing centers across the country. We're hoping that we'll put to bed all that great education. And rightly, they are on. Could you continue?
Thank you, Roland. And thank you so much, Professor Ampofo, for your patience. It's very difficult sometimes working this technology, but it's good to have you back. Now, just before we lost you, you were walking us through the explanation of how these PCR tests are done.
Yes. So as you've heard, the PCR test just means polymerase chain reaction, and it's a molecular test that is used for the direct detection of the pathogen concerned. So it is used to directly detect bacteria. Those are usually what you call DNA, and then viruses, which are both RNA and DNA, ribonucleic acid and deoxynucleic acid. So this is a very standard procedure used now because you're able to amplify, you're able to detect the smallest amount of the pathogen present by an amplification process. And what we're using is a real-time process where as the chemical reaction takes place, you're able to see it in real time on the computer screen. And it actually gives you a measurement of the amount of virus that you started with. So it's quite a very reliable tool in advanced diagnosis now.
Thank you for that. Now, my understanding is that the samples are taken from the patient using a swab, so in the nose or the throat, and then these samples are then put through the process you just described. Now, at the moment, we're working with batches of 10. You started off with 5, now we're doing batches of 10. So what I want to understand is, I keep hearing the term test kit. But from the description you've given, it seems we're just taking swabs and then applying reagents, in batches. So where from the term test kit, and when we say we are ordering test kits and so forth, what exactly do we mean when we say that?
Okay, so the term test kit applies to a simple set or a simple device together with its collecting, material that is used to test for a pathogen. Okay, and the term arises from the application of a rapid diagnostic test kit. So sometimes when you hear people say test kit, they're actually referring to that simple thing, like a pregnancy test,
Right.
It's like usually, the common term maybe arrived from HIV, where we have a rapid diagnostic test kit. It became short RDT, and sometimes people just say test kit. So
right.
They are applying that term also to the coronavirus testing. But when we talk about respiratory viruses, we do not use a test kit per se, because the testing for respiratory viruses is currently based on molecular tests. That is the PCR test, which is uses a respiratory sample as a starting material. Usually, when we say a test kit for the other pathogens, we're actually referring to a blood sample, and this is usually put on a rapid diagnostic test kit. So I'm glad you brought this up so that the difference is made clear. So for this coronavirus, if you check in the USA, the president has been talking about ramping up molecular tests. Also in China, it was molecular PCR tests that were used. Same thing in South Korea. I think there has been some discussion about the application of rapid diagnostic test kits to enable and facilitate testing for the coronavirus. So that's what we explained, that is something that we are also considering, and that is a subsequent point we will discuss.
All right, thank you so much for that. So what this means is when Jack Ma, for example, donated 21,000 test kits, when the president ordered 50,000 test kits, what exactly was ordered? What did we order?
So again, this is again the simple terminology. So 20,000 PCR kits, because now we have an advancement in PCR technology where a box has been made, a package has been put together, which has the different enzymes that you need to conduct a PCR test. So we've moved on from a couple of years back where the components were separate and you had to buy different components, especially for research. Now for this kind of public health, molecular testing with PCR, some of the companies are packaging the PCR, testing in one package. So you can have the enzyme and the other stuff that you need in one package. And that's why the term test kit was applied to the PCR donation from Jack Ma.
Okay, so for each of these boxes that we've got, how many samples can you test with each box?
Oh, you can test, usually it differs by manufacturer. One manufacturer would put a package together which has 20 PCR tests. Another manufacturer would do 50, another would do 100. So it depends on the manufacturer. We've also had PCR test kits supplied by the WHO and by the Africa CDC from a German company. These have all come packaged, to do a certain number of tests per package. Yes.
Right. You see, the reason why I'm asking this is I'm trying to get my head around our capacity at the moment. Whether we are anywhere close to running out, or whether we have enough to test the entire population. So, can you give us an idea?
So that is one of the major logistics issues we are dealing with. When we initially started, we had enough to do about 1,500 tests. And then I think if I remember, we got 1,000 from Africa CDC. We then got another 3,000 from Africa CDC. We got also 2,000 from WHO. We also got 1,000 from the West Africa Health Organization. So, and then the Jack Ma, kits came in, which were 20,000. Okay. So, along the line, we did what we call, we do trials, experiments. Okay. And we worked out the minimum volume, okay, of these enzymes and probe mixes that we could apply. So what we have found is that we're able to reduce the amount of the primer probe mix. This is the chemical that we use for the PCR. So we're able to do more with the same amount than what the manufacturer prescribed would do. And this is a common method in research. So you get a container, it says you can do 20 tests. We're able to modify using a research technique, and then we're able to do 40 or 50 tests. So we're able to double the number of tests that we can do with
Does that affect the validity of your results? I mean,
of course, it does not. It does not, because all these assays that we do has a control, okay? So, of course, the manufacturer sets his criteria, and then we in-house, make our adjustments, because this is a public health emergency. We want to be able to produce the results as efficiently as possible, but still have valid results. So in line with the criteria to declare positive, we make an adjustment to the working concentrations. And of course, so long as our positive controls and also our in-house controls, both negative and positive, are working, we're able to, come up with a system where we're able to ensure that the results are valid. I would invite you to the lab, because you actually see that the number, you actually see in our database, and this is raw records of the PCRs. You see the number of repeats that we have to do if the test is not valid in line with each manufacturer's criteria. We follow this strictly. So this is a standard procedure.
I would love to take you up on that invitation, actually. Okay. I'd love to come over later and then have a look.
I'm glad you asked the question about logistics, because this has been a major challenge. Okay. In fact, this is the reason why we've not been able to roll out to other centers that have, PCR capacity, because of the limited amount of PCR kits, and then also the accompanying lab supplies that are needed. In fact, I'm sure that if it wasn't for the fact that we are a research institution, we would not have been able to do more than 10,000 tests because of the associated consumables that are required. We've had to use resources from other departments and also from ongoing research projects, which have all been suspended because of the coronavirus outbreak. That's how come we've been able to, maintain this level of testing. Of course, supplies have been ordered. Some have started to come in, but you know that with the closure of many countries, air travel is restricted, and there's pressure on the cargo airlines that are operating. So logistics has been very, very difficult.
This is an important point, a real big hurdle we need to overcome. Now, I noticed you mentioned a number of kits that came through, that 1,500 and another 1,500 and then 3,000, then 2,000. And then you mentioned the 20,000 donation from Jack Ma.
Yes.
I didn't hear you mention the 50,000 that the president said they were going to order. Has that not arrived yet?
50,000 kits. Yes, we've also bought 10,000 QIAGEN kits. We also bought 20,000 PCR kits. So as I said, we have a list of PCR kits and also RNA extraction kits that we have ordered and have come that we are using. And for each kit that we use, of course, we have a standard procedure that we adopt. So we have used the type of PCR kit depending on the kind of analysis that we are doing. Currently, we are using the Jack Ma kits in all the centers in Ghana. That is the standard kit that we are using. So of course, we have the WHO kits and we have the other kits all, on standby, because the largest amount of testing capacity that we have is with the Jack Ma kits. And we wanted to ensure that what we are using in Public Health Reference Lab, what we are using at VSD, what we are using at Noguchi, what we are using at KCCR are all standard.
All the same.
Yes, we're all using the same kits and the same protocol.
So what I'm getting from what you're explaining is that the 50,000 kits that we heard that the president would order, those have not come. So you're working with the other ones.
Yes.
Right. Okay. Do you know where they are being ordered from? Are you part of that process?
It's made by a company called Danjin in China.
Right.
We've already reviewed how it works according to our in-house standards and according to we actually started with a standard virus from the European Virus Diagnostic Center. It's in Europe. It's one of the standard centers for Europe. And that was our virus standard that we set out together with the KCCR. And this control has established all the procedures that we do testing. I think I did mention this yesterday that we've also exchanged positive and negative samples between us and KCCR to serve as internal, external quality control systems for Ghana.
Okay, so do you know when we will be receiving the 50,000 from China? Do we have a delivery date?
We don't have a delivery date, but so far we also have orders for other suppliers. So we're confident that as we move, and this is a staggered thing. The other thing that you're probably not aware of about is that we have machines in country called GeneXpert, and these are used for TB. And the company Cepheid has developed a diagnostic kit for coronavirus, and an order has been placed, I think. And there are 130 GeneXpert machines all over Ghana. So the rollout that you had, the 50,000, it also includes running systems on this GeneXpert, which is in 100 centers all over Ghana. So we have a national lab plan strategy, and this is being resourced, and we hope that we will be able to have testing centers in each major capital soon.
Right. So what you just described is a network of about 100 other places that can do this testing for the coronavirus.
Exactly.
Okay. They just need to be resourced.
They need to resource. The order with the company has been placed, and there are a couple of issues that need to be worked out. There are some associated equipment that need to be established as well. So this is all, as I told you, is all part of a national strategic, short-term plan for coronavirus that we are adopting.
How soon do you think we'll be able to have these 100 sites online?
Well, other countries have also placed their orders for the resources. So we've been told that sometime in May. We were hoping that, first, second week in May, but we will only be able to give a timeline as soon as we get the delivery date from the manufacturer. And then we will then, continue with the preparation and the rollout. These sites are already using these machines for TB. So it's just a matter of just putting on the coronavirus software and then running the assays.
Right. Is it possible then for us to test every Ghanaian?
To test every Ghanaian, that would be a difficult. We have 25 million Ghanaians. I think that would mean significant, manpower, resources. Let's put it this way. In every major center where there is a gene expert machine, they will be able to offer, testing. And I think the focus would be, this is my own personal opinion, the focus would be, because they're in health facilities, it would be on people who, have respiratory illness, and the clinicians need to rule out, the different pathogens, including coronavirus, TB, etc. So that would be the way to go.
Right.
But testing every single healthy person, I don't think it's a public health strategy, because this is a respiratory virus. You could have the infection today, and a month later you could get exposed again. So you would need to be constantly testing everybody every month or every quarter if you want to use that as a public health tool. It's impossible to do 25 million tests every quarter.
Okay. So there was also the talk of doing these rapid tests. Actually, let me clarify that. There was talk of doing antibodies testing. Tell us about that and why that is important. Okay.
So because these are respiratory viral infections, everybody gets exposed every time. Coronaviruses are present in Ghana. This is a novel coronavirus. So if you're going to test for the coronavirus using antibodies, you need to ensure that the test that you are going to use to detect antibodies to novel coronavirus is not cross-reacting with the other human coronaviruses. There are 4 of them,
right? And
we name them according to different numerals. Okay, so these are already, in Ghana, from our studies on influenza surveillance, we picked up, and our colleagues in KCCR have done, studies on this also. So these coronaviruses are around. So because of that particular fact, you can't just introduce any rapid diagnostic kit for antibody detection. You have to ensure that these antibody kits are highly sensitive. That means they're able to pick up true positives, and that they are highly specific, that they're able to pick up true negatives. This is what we do for HIV. All the test kits that are used for HIV in Ghana have been evaluated, their sensitivity has been determined, and the algorithm has been adopted accordingly. So the same thing for coronaviruses. We advised government that we needed to evaluate, any rapid diagnostic kits for coronavirus, and the FDA has accordingly produced a guideline that is in place as the framework for the use of rapid diagnostic kits. I mean, for public health, we would love to, do as much testing as possible, but the advice from WHO and then the other international agencies, especially the Africa CDC and WAHU, have been that you could use them for a survey, knowing exactly what you're looking for, but note that you need to interpret the results cautiously, because exposure, presence of the antibody, may not equal to infection, which is what you do when you do a PCR. So you need to be clear about what you want to do. You don't want to test 100 people, all of them will be positive, and they will go away thinking they have coronavirus infection, when the data just shows that they have been exposed to the coronavirus, have probably recovered, and are healthy. So there is some caution about the application of the rapid diagnostic test kits to detect antibody. And there is some discussion about what would be the best combination of the PCR kits, which pick up the virus itself, and these antibody kits, which pick up the antibody showing that you've been exposed to the virus. So these are discussions that we hope that when we are able to evaluate the incoming antibody test kits, advise government on which is most sensitive and specific, then the experts will also then come up and say, okay, we'll do this way in combination with PCR, so that we could have a clear picture of what is happening in Ghana.
Right. So at the moment, you've talked about the logistical constraint. Now, assuming that our order will come in May or whenever it is that we're expecting the 50,000 to come in, are we okay till then? Do we have enough to go on with the rapid testing, the enhanced contact tracing and testing till then?
Yes, my feeling is that the enhanced contact tracing that was done in Accra and Kumasi was to get an idea in our two key major cities. And so what I understand from the Ghana Health Service is that they're going to do a targeted approach where the surveillance will be linked to the lab capacity so that the surveillance ensures that it achieves its true aim of identifying positives, isolating them, and reducing the transfer or spread in the community. So I understand that it's going to be targeted going forward. And as I told you, we have currently orders, which we are hoping that these would arrive ASAP, and then we could resource, testing centers, outside Accra and Kumasi, where we know that there is existing PCR, capacity. You've heard talk about the Veterinary Service Directorate. They have labs with PCR capacity in Accra, in Sekondi Takoradi, and in Pong Tamale. So there is the plan to include them in the testing. We've done an initial assessment, and we're hoping that we will get them online very soon. There are also other laboratories in the Wa Memorial Hospital in Avrongo. There's also the Tamale Teaching Hospital. There's a public health lab that has also PCR capacity that our colleagues in KCCR have assessed, and we're hoping that ASAP we could also bring them online.
Right. Now, you're a virologist, am I right?
Yes.
Okay, so perhaps you can help me with this. We're moving from enhanced, testing, if you like, to targeted testing. But our numbers are up, which means that the number of people who are positive is higher than it was when we were doing enhanced testing or when we started enhanced testing. Are we not rather now in a position where there might be exponential, infection? Why are we going to be testing fewer people?
I didn't say we'll be testing fewer people. I was saying that the testing would be targeted. So,
right.
So that would be a more efficient use of the resource. Of course, surveillance means that person, time, place, look at wherever there is an issue and also test. And that's the way actually the testing has been going on. Remember, we started with the with incoming travelers, okay? And then with the case definition was anybody who had traveled recently. So the testing has always been targeted. It has not been mass testing. It has always been targeted. And that strategy, I understand, is what we are pursuing.
I suppose I asked you that because my initial question was, do we have enough to last us until May? And you said, yes, because we should be doing targeted testing. So you understand why they gave me the impression that perhaps, we're going to be doing testing fewer people, which is why we will last until May.
We actually, as I said, with this, it's how do I say? It's a dynamic process. Okay, the order from Jack Ma could come in anytime, so that would still be in April. We have other orders, as I've told you, which are dependent on the ability to go through the air cargo bottlenecks. So as we scale up, that's why we are not scaling. That's why you don't hear of testing ongoing in Avrongo now. We have to ensure that the associated reagents, lab supplies are in place for them to have sustained testing. Yes.
So who are we targeting now?
That question will have to go to the Ghana Health Service. The Ghana Health Service, our colleagues in surveillance, they look at the risk from the hotspots, the data they've gathered, and they combine this with reports from the regional directors for health, and then they come up with what would be the appropriate strategy, which I understand is targeted and not mass testing. That's why I mentioned that specifically.
Okay. Just before you go, one little clarification, and it's just a numbers thing. I've been looking at the breakdown on the Ghana Health Service website of the number of tests that have been done. And it says that for the mandatory quarantine, 2,022 tests have been done.
Yes.
My understanding was that there were only just a little above 1,000 people quarantined. So how do we explain the 2022 tests that is recorded here by the Ghana Health Service?
There were people associated with the mandatory quarantine. So they probably put all that together. And they also remember that when people were positive, they either do home care or they are put into quarantine. So you could have probably some people from the recent community, enhanced surveillance who have also been quarantined. So that could probably account for it. But I do not know the details because we do the testing and then we provide the results for them. So it could have been a quarantine case, but it could have been labeled as contact tracing. It could have been a suspected case in a hospital, but it could still have come from, a mandatory quarantine. Okay. So they know specifically where they've broken it down.
But I'm guessing what you're saying is that that would not be from you. That's not for you to answer. Okay. Yes. All right. Professor William Ampofo, I've got to say a big thank you for the time you've spent with us and all the explanations. We really appreciate it. And I'd love to come over later today, so I'll give you a call and see.
Look, we had your colleagues from CTFM come. I think they did a nice documentary. We'll invite you guys to spend time with us so that you look into the systems, you see exactly the work we do, and my colleagues feel very appreciated because they've done a lot of work. 150 people working day night, for over 2-3 weeks. It's been a tough job. Yeah.
I look forward to that. Thanks once again.
Thank you. All right, a pleasure.